October 16, 1846. A man lies on a wooden table inside a crowded operating room in Boston. A surgeon is standing over him with a knife, and dozens of doctors are leaning forward to watch what happens next. Normally, this would be the moment when the patient would scream, fight, or have to be held down while the surgeon raced to finish. But this time, something is different. The man is lying still, breathing through a strange glass device, while the surgeon prepares to cut into his neck. And if this experiment fails, everyone in that room is about to watch a human being suffer in front of them. The patient does not know it yet, but he is about to become part of one of the most important moments in medical history. For thousands of years, surgeons had been able to cut, stitch, remove damaged tissue, and even amputate limbs. But pain stood like an invisible wall in front of them. They could make the operation faster, but they could not simply turn the pain off. Then, in this Boston room, a young dentist is about to prove that the wall may not be as permanent as everyone thought. Before we uncover exactly what happened on that table, subscribe to the channel, because this is the story of how medicine finally learned to fight one of its oldest enemies, pain. Long before hospitals had bright lights, heart monitors, and machines that could breathe for a patient, surgery was an entirely different kind of experience. Imagine knowing that a surgeon could possibly save your life, but also knowing that the operation itself might be one of the most terrifying experiences a human being could endure. There were no modern anesthetic machines waiting beside the table, no carefully measured mixture entering a vein, and no specialist watching your breathing every second. If you needed an operation, the surgeon's greatest advantage was often speed. The faster the knife moved, the shorter the agony lasted. People had not simply ignored the problem. Ancient physicians experimented with anything that seemed capable of making a person sleepy, numb, or less aware of what was happening. Opium could dull the senses, alcohol could make a patient less aware, and plants such as mandrake and henbane were used in different mixtures across centuries. Some traditions even used sponges soaked with drug mixtures in an attempt to make patients sleep through procedures. But these remedies were more like trying to control a storm with a candle than operating a reliable medical system. Too little might leave a person fully awake, while too much could push them into a dangerous state from which they might never wake. And there was another problem that was just as important as pain. A frightened person does not naturally lie perfectly still while someone cuts into them. Muscles tense, hands move, the heart races, and the instinct to escape becomes almost impossible to suppress. Surgeons therefore had to work with the body rather than simply against the disease. An operation that might take an hour today could become a desperate race against the patient's ability to endure it. This is why speed became a strange measure of surgical skill. The surgeon, who could finish fastest, could sometimes give the patient the best chance of surviving the experience. But then, the 19th century brought an unusual new possibility, and it did not begin inside a hospital. It began with people entertaining themselves. In the early 1800s, gases such as nitrous oxide became popular at public demonstrations, where people inhaled them and behaved in strange, laughing, sometimes wildly uncontrolled ways. Audiences saw people become giddy and careless about bumps and minor injuries. Most people saw entertainment. A few doctors saw something else. They began to wonder whether the same strange state that made a person laugh might also make a person unable to feel pain. One of those doctors was an American dentist named Horace Wells. In 1844, Wells watched a public demonstration of nitrous oxide and noticed that one participant injured himself without seeming to notice the injury immediately. Wells understood the possible meaning almost at once. If a person could become so detached from pain that an injury barely registered, perhaps a dentist could remove a tooth without the patient experiencing the usual agony. The idea sounded almost too good to be true. But Wells decided that the only way to find out was to try it. The next day, Wells had a healthy tooth removed while he inhaled nitrous oxide. The experiment appeared to work, and Wells became convinced that he had found something important. But discovering something in a small experiment is not the same as convincing the world. Soon, Wells attempted to demonstrate the technique publicly before doctors in Boston. The result was a disaster. The patient reacted during the procedure, the audience was unimpressed, and Wells left humiliated. That failure is one of the strangest turns in the story, because the idea itself was not necessarily dead. It had simply failed at the moment when Wells most needed it to succeed. And somewhere in that circle of doctors was another dentist who had watched what happened. His name was William T.G. Morton. Morton was ambitious, curious, and increasingly interested in the possibility of finding a substance that could produce a deeper state of unconsciousness. He would soon try a different substance, and this time the result would be very different. But before Morton could claim the spotlight, there was another man whose story would later become painfully important. His name was Crawford Long, a physician practicing in Georgia. In 1842, years before the famous Boston demonstration, Long had already used ether to make patients insensitive during surgical procedures. He used it for operations, including the removal of tumors. The astonishing part is that Long did not immediately publish the discovery and announce it to the medical world. As a result, the medical revolution he had quietly demonstrated in Georgia did not spread when it could have. That distinction matters because history is not always kind to the person who gets somewhere first. Sometimes the discovery exists in one room, but the world does not hear about it until somebody else shows it in a way that cannot be ignored. Long had used ether. Wells had experimented with nitrous oxide. Morton was now searching for a method he could demonstrate convincingly. And while Morton would eventually receive enormous attention, the story would become tangled with arguments over who deserved credit. But all of those arguments were still ahead. First, Morton needed to prove that his strange idea actually worked. The substance he turned toward was ether, a volatile liquid that had been known for centuries and was already familiar in medicine and chemistry. Ether was not some magical substance created specifically for surgery. It had been used for other purposes, and people knew that inhaling its vapors could produce a powerful altered state. Morton began experimenting carefully, first using it in dentistry. Then, on September 30th, 1846, he used ether on a man named Aben Frost for a tooth extraction. The tooth came out, and the patient did not experience the usual pain. For Morton, this was the moment when a wild possibility began to look like a real technique. But pulling a tooth was not enough. If Morton wanted the medical world to believe him, he needed to prove that ether could survive a much bigger test. A major operation would expose every weakness in the idea. The patient would have to remain still long enough for the surgeon to work. The unconsciousness would have to last long enough. And Morton would have to administer the substance without accidentally giving too much. One mistake could turn a miracle into a tragedy. Yet Morton pushed forward, and soon an opportunity appeared at Massachusetts General Hospital. The date was October 16, 1846. Inside the hospital's surgical amphitheater, doctors gathered around an operating table. The patient was Edward Gilbert Abbott, a young man who had a growth on his neck that surgeon John Collins Warren intended to remove. The room was packed because everyone understood that something unusual was about to happen. Morton arrived with an inhaling device containing ether. To the people watching, it probably did not look like the beginning of a new age. It looked like an uncertain experiment that could fail at any moment. Morton placed the device over Abbott's face. The patient inhaled. The room waited. Gradually, Abbott became deeply unconscious, and Warren began the operation. The knife entered the tissue, the surgeon worked, and the patient remained remarkably still. There was no desperate struggle and no familiar scream. When Warren finished, he turned toward the room and made the significance clear. The patient had felt little or no pain from the operation. That moment became known as Ether Day. It did not mean that anesthesia was suddenly perfect. It did not mean every surgeon immediately understood how to use it safely. And it certainly did not mean Morton had been the first person ever to discover the effect of ether. What made the event so powerful was that a room full of medical professionals had witnessed a successful major operation under anesthesia. The question had changed from, "Could this possibly work?" to, "How quickly can we learn to use it?" The news spread with astonishing speed. Surgeons in other countries began trying ether. In Britain, Robert Liston famously performed an amputation under ether in December 1846. Reports of successful operations traveled through medical communities, and the operating room began changing almost before doctors had time to fully understand what they had unleashed. For the first time, surgeons could imagine taking their time. They could examine a problem more carefully instead of simply racing through the most painful part. Operations that had once seemed impossible began to move within reach. But the new freedom came with a dangerous catch. Making someone unconscious was only half the problem. Doctors still had to understand how much anesthetic was enough, how to keep the patient breathing, and how to recognize when the drug was becoming dangerous. The first anesthetics were not precise modern tools. They were more like powerful engines without reliable dashboards. Doctors could make the patient disappear into unconsciousness, but they were still learning how to bring the patient safely back. Then, another substance entered the story: chloroform. In 1847, Scottish physician James Young Simpson discovered its anesthetic properties while searching for alternatives to ether. Chloroform was potent and, for some doctors and patients, easier to use. It soon became popular, especially in obstetrics. In 1853, physician John Snow administered chloroform to Queen Victoria during the birth of her 8th child, helping make anesthetic use during childbirth far more socially acceptable. But popularity did not make chloroform harmless. Some patients died after receiving it, and doctors gradually learned that anesthetics could affect more than a person's awareness of pain. They could influence breathing, circulation, and other essential functions. This was the point where the story stopped being simply about finding a drug that could make people unconscious. It became a much harder challenge. How do you control unconsciousness without losing control of the person? That question would eventually create an entirely new medical specialty. But before that happened, another revolutionary idea changed the game again. What if a patient did not need to be completely unconscious at all? What if you could make only the part of the body being operated on stop feeling pain? It sounds simple now, but at the time, it was another enormous leap. Instead of shutting down the whole house, doctors were beginning to imagine turning off just one room. The breakthrough came through local anesthesia. In 1884, Austrian ophthalmologist Karl Koller demonstrated that cocaine could numb the eye well enough to permit certain procedures without the patient feeling the expected pain. The discovery spread quickly. Doctors began exploring ways to use local anesthetics around nerves and tissues. The basic idea was beautifully simple. Instead of sending the patient into a deep sleep, block the pain message before it reaches the brain. Think of the nervous system like an enormous network of telephone lines. When you touch something hot, a message races along those lines toward the brain, saying, "Danger, pull away." A local anesthetic acts like someone cutting the telephone wire for a short distance. The injury may still be happening, but the message cannot travel normally. The brain therefore receives far less of the warning. Cocaine itself was far from an ideal long-term answer because it could be toxic and addictive. But the principle it revealed was enormous. Doctors did not always have to knock out the whole person to stop pain. And then they pushed the idea deeper. In 1898, German surgeon August Beer performed an early spinal anesthetic by introducing cocaine into the fluid around the spinal cord. The result allowed surgery on parts of the body below the level of the block, while the patient could remain conscious. Imagine sitting awake while surgeons operate on your leg, knowing they are touching you, seeing them move around you, yet feeling almost nothing where the operation is taking place. It was another moment when medicine discovered that pain and consciousness were not the same thing. But early spinal anesthesia was not the polished technique used today. Patients could experience severe headaches and other complications, and doctors still had much to learn about the nervous system. Once again, the pattern repeated itself. A breakthrough opened a door, and behind that door was another problem waiting to be solved. Ether created the challenge of controlling unconsciousness. Local anesthesia created the challenge of safely blocking nerves. Spinal anesthesia created the challenge of working near the most delicate pathways in the body. Progress was becoming less about finding one miracle and more about mastering a whole collection of smaller miracles. By the 20th century, anesthesia was beginning to transform from an improvised technique into a serious science and medical specialty. Anesthetic machines became more sophisticated. Doctors learned better ways to deliver gases. Airway devices improved. Techniques for controlling breathing became increasingly important. Instead of simply placing a cloth or crude inhaler near a patient's face, anesthetists could increasingly control exactly what entered the patient's lungs. This changed surgery itself. If a surgeon no longer had to finish before the patient could tolerate the pain, the operating window became much larger. Surgeons could work more slowly and carefully. They could attempt procedures inside the abdomen and chest that would have been extraordinarily difficult when every second of pain mattered. They could repair structures rather than simply remove them. The operating room was no longer a place where speed alone determined what was possible. But there was an even deeper transformation happening. Doctors were learning that a patient under anesthesia was not simply asleep. The body was still working, and it still needed oxygen. The heart was still pumping. Blood pressure could rise or fall. Breathing could become weak. Temperature could change. A modern anesthetist therefore had to watch the entire person, not just the patient's level of consciousness. The revolution followed, but the story was not over. Pain was only the first barrier. Once surgeons could silence it, they began asking what else was impossible. The answers would change medicine forever. Subscribe for the next chapter.